How's Professor Zhu in your hospital in Shanghai? He was. Is he still active?
Yes, yes.
That's right.
Professor Zhou, yes. Liang Fu Zhou, yeah.
Right. Would you say hello to him for me?
Yes, yes.
Oh,
okay.
thank you.
Actually, Professor Yuha Hanesnemi, and we will have a Shaolin International Conference, and he will presented an award to you in the in I think it's in June, in middle of June.
And are you in a new hospital now, or I was reading about that?
Yes.
And it's a large hospital, I understand. Is that correct?
Yes, yes. Now we have 4 campuses in Shanghai.
Okay, we're live on YouTube.
Yeah.
Let's start. 10, 9, 8,
Okay.
7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett, televising from Miami Beach in Florida. We have the honor of televising our bi-monthly China Neurosurgical Journal Webcast, and we have James Ausman, quite a name, Neurosurgery, and I'll let Ben Zhu give the proper neurosurgery introduction. Welcome, Ben.
Okay, thank you, John. And today we are very happy to invited Professor James Ausman, and who is a real master of the neurosurgery. And today he will presented his opinion on the future of the neurosurgery and the medicine 2100. Please.
Okay, thank you very much. John, I'm going to share screen here. Okay, can you see my screen now?
Yes, perfect.
And everybody can hear me?
Yes.
Okay. Well, I'll start by saying I am going to give you my view of what I think neurosurgery and medicine will look like in the next 80 years. It's just my view. I could be wrong. I could be right or partially right, but it's just a view from somebody who's followed what's going on in medicine and neurosurgery for some years. I'll start with a case. And this is a case of a 60-year-old man who came to the clinic with a sudden hemiparesis. It was a pure motor paresis, which means it was likely in the internal capsule. He had otherwise he was fine, had all the features you would expect with a paralysis, with the hyperreflexia and the paralysis in the motor system. I had a CT scan, which showed these lesions. You can see one is in the internal capsule, it's circled in red, and you see the other lesion here. And these were called lacunar or capsular infarcts. And the reason for that, I'm going to show you now, was because it was believed that the blood supply to the basal ganglia, as you can see here in this part of the slide, came off of branches of the middle cerebral and anterior cerebral artery that fed the basal ganglia. Sometimes we get hemorrhages from these vessels, you can see that. And but this is what it was thought to be. There was a professor of neurology at Massachusetts General Hospital His name was C. Miller Fisher. And in this paper in Archives of Neurology of 1979, he published a study of patients who had these lacunar infarcts. And what he found is he followed 10 patients. He followed them clinically, and then after they died, the brains were autopsied, sectioned, and he sectioned the brain, if you can believe this, sectioned the brain from 1,000 to 4,000 sections, starting from the infarct lesion that we see here and going all the way down to the origin from the ventricular striate vessels. An incredible amount of work. This is the major paper on this subject in the literature, and that's what he did. This is what he found. And this is a section of the brain. You can see this is the vessel wall here is the middle cerebral artery. Off the middle cerebral artery comes a lenticulostriate branch, and the branch is partially occluded, and it's occluded by a fatty deposit that we call atherosclerosis, but it's basically macrophages filled with fat. And this is going to become very important as we go in the talk. He studied these 10 cases, and then he determined what the origin or where these plaques were located. And he found that many of them were very close to the origin of the lenticulostriate arteries off the middle cerebral system or the anterior cerebral system. If you look at one of the vessels and specimens he has, you can see the lumen has narrowed. It's filled with red blood cells. And the rest of it is filled with fatty deposits. These are macrophages filled with fat. Nothing much was done during that period of time. We went to the laboratory. We had a person who worked with us, Dr. Duhovny, Dr. Moises Vasquez from Peru. And we studied, injected brains of people who died looking for the anatomy of the lenticulostriate vessels. In this view, you can see the optic nerve here. You can see the internal carotid artery coming up from the neck. In this view, you can see the anterior cerebral artery here in red. And we divided the middle cerebral artery into a proximal portion and distal portion. Proximal was in blue, the distal was in yellow. And what we did is injected each isolated segment of the vessel with a different color dye. So the distal middle cerebral was injected with yellow. The proximal middle cerebral was injected with blue, and the anterior cerebral system was injected with red. And then after that, we sectioned the brains. I'll show you another picture here. We did a number of these specimens. I think there were 40 specimens. And you can see right away that in this specimen, the distal middle cerebral has a smaller number of lenticulostriate arteries. The middle cerebral vessel has a smaller number, as does the anterior cerebral. We see the recurrent artery of Hubner here. We see another, which is a short central artery. And compared to this, there are fewer lenticulostriate vessels. And so that's one of the first points I want to make. And that is the vessels that come off, the lenticulostriate vessels that come off, the anterior and middle cerebral artery can differ in number. And they can differ in how many come off from proximal or distal segments. Now, what we did then is section the brain. And you can see in this one brain, if you look at the right and left half of the brain, you see the red from the anterior cerebral artery filling most of the basal ganglia here. It's some of the caudate nucleus and the putamen. But if you look at the other side, the anterior cerebral on that side, lenticular striate vessels do not fill the same amount of territory as filled on the opposite side. And you can see a little yellow color here around the edges here. Here's going to be the internal capsule. And you can see that's fed by a branch off of the distal middle cerebral artery. So they have the anterior cerebral artery feeding this distribution, the distal middle cerebral feeding here, and a very small portion from the proximal feeding and going to the basal ganglia. On the other side, you see a very tiny blue spot, which is the middle cerebral proximal, and a very small branches coming from the distal middle cerebral artery. So what we're seeing is in the same patient, the vessels that supply the vascular supply to the basal ganglia differs in the same patient from one side to the other. On one side, the anterior cerebral is very dominant. On the other side, it's a mixture of anterior and middle cerebral, mostly here distal middle cerebral, as opposed to proximal middle cerebral. If we go back and look at this film here, this image here, you can see how that can happen. If the distribution from the distal middle cerebral is very significant or very great, that will supply the basal ganglia. Or the middle cerebral is very great. But if it's small, it will not supply it at all. After we looked at this section, we looked at sections of the other brains. And what you can see here is something very interesting. You see in this brain, the anterior cerebral fills the caudate part of the basal ganglia on this side, but not on the other side, which is filled both basically by the middle cerebral, proximal and distal branch. Some here in the globus pallidus and putamen is filled by the anterior cerebral. So the distribution of blood supply in this patient is different from one side to the other. And it's different between patients. And as you look at the next patient here, most of the supply comes from the middle cerebral proximal. On the other side, it's both yellow and blue, and it's coming from the middle cerebral with very little coming from the anterior cerebral. If we look at some more brains, you see here the anterior cerebral has some distribution on this side, less on the other side. We see the proximal middle cerebral, and we see some yellow, it's hard to see it, but some yellow color filling the rest. So the distal middle cerebral is dominant. On this side, we have middle cerebral in this brain. We have the yellow from the distal, blue from the proximal, and very little from the anterior cerebral. Some is staining red with yellow mixed here. So what did we learn? We learn is not only the supply of lenticular striates from the anterior and middle cerebral variable in the same patient from side to side, but the distribution in the supply in the basal ganglia is markedly different in the same patient, here you see this, or among patients or in different patients. So how do these patients present? I'll go back to this slide here. If this patient here has an embolus in the middle cerebral, that could affect this part. If he has collateral circulation into the distal, those vessels would still be supplied, the anterior supplies. If these vessels, the red and the yellow, are dominant in supplying the basal ganglia, you will not see anything if he has a blood clot in the proximal middle cerebral. So you can see clinically that these would present very differently. So now we'll come back to the original study that Dr. Fisher did. And you can see that, first of all, lacunar strokes represent 20% of all strokes. 20%, 1 out of every 5. And we don't know how to diagnose it. We don't know how to find it, and we don't know how to treat it. And I told you his paper was in 1979, 1980. That's 40 years ago. And we still don't know how to diagnose or treat this disease, and it causes a major percentage of strokes. So that's where we are. So how can we diagnose this? Well, we use imaging. And this is an example of a 1.5 Tesla image, a 3 Tesla image, and a 7 Tesla image. There are very few 7 Tesla scanners around the world. Most of us have 3 Tesla. We started out with 1.5 Tesla, and you can see the detail in 1.5 Tesla is very good. We still see the white matter. We see the cortex. We see the white matter. But the detail then becomes not well defined. When we went to a 3 Tesla magna, we see more detail. And you can see more detail in the cortex and the white matter. You can even possibly see a little nucleus here of cells. If we go to a 7 Tesla scan, the detail becomes very impressive, very significant. You almost see different nuclear bundles here, nuclear areas of neurons that are located. And so with 7 Tesla, we can see more than we can see with 3 Tesla and 1.5 Tesla. Okay, now let's see what happens with a 1.5 Tesla MR angiogram, a 3 Tesla, and a 7 Tesla. If we look at a 1.5 Tesla, you don't see very many vessels. So we're trying to ask the question, how are we going to diagnose 20% of these strokes? And with 1.5 Tesla, we would not have much of a chance. 3 Tesla, you see the blood vessels here are very well represented, very detailed, in both hemispheres. Even the blood vessels, small blood vessels below the cortex going into the parenchyma, and these vessels are less than a millimeter. They're probably 500 microns. And using a 7 Tesla, you can see the detail is even much more defined. So will this help us make a diagnosis? Right now, this is not used to make a diagnosis of this disease. Well, what else can we do? Can we do angiography? Well, today, angiography will only show us blood vessels that are about a millimeter or 2 millimeters. We can't see below 1,000 microns. But these vessels, I told you, are probably 500 microns or 50 to 400 microns in size. How can we see them? Well, I visited a center some years ago in the United States, in which they took a small catheter and they were able to put it up the middle cerebral artery and inject it into a lenticulostriate vessel. It was a 50 micron catheter. So we do have a way of diagnosing it, but most people don't do that. And the reason they don't do that is, if I find it, what am I going to do? And the answer is, we don't know what to do. There's nothing. So why diagnose it? So the diagnosis then becomes clinical. So I'm going to tell you about a patient. This was a paper we published in Surgical Neurology International in 2014. That's 9 years ago. This is a patient from a Japanese neurosurgeon. A 45-year-old male came to them, and he presented with dizziness and visual field deficits. On examination, he had homonymous hemianopsy, he had an occipital lobe infarct. And at that time, they didn't do much for him. This is now what I've told you, 2014. And he was treated with aspirin. That was the treatment at that time. A man came back 6 months later. He had a loss of consciousness. And the MR angiogram showed both vertebral arteries were occluded. Well, what's happening in this patient? Why did he lose consciousness? Why did he have an occipital lobe infarct? And this was a set of his imaging studies, and I'll take you through them. Here we see a carotid angiogram, the right side. You see there's no posterior communicating artery. It should come off about right here off the carotid artery. It's not there. We don't see it. This is an angiogram. And I told you it shows us vessels from 1 or 2 millimeters and larger. We see a little small stain here. We don't know what it is. We look at the opposite side. There's still no posterior communicating artery. But you see there's a vessel coming here. We don't know what it is. And it begins to fill the basilar artery. Now, what is that? So we have a man who's got both carotid arteries open. He has no posterior communicating arteries. His vertebral arteries are occluded. How's he living? It explains how he could have an occipital infarct. It explains how he might have a loss of consciousness because he has very limited supply to the posterior circulation. Now what we do is a 7 Tesla MRA. And what we see, and that's looking at this vessel here, what you see is here's the carotid, and we still don't see the posterior communicating artery, but you see this vessel. It's kind of a wavy, what we call corkscrew pattern, wavy pattern, which goes back, and it may fill part of the basilar artery. But we take the view on the other side. We take the view of both sides in the proper section. You see, here is that vessel coming off of one side, going back and filling the posterior cerebral artery. Here's the one on the other side filling the other posterior cerebral artery. And this is how the patient is supplying his circulation to the cerebellum and brainstem. But by conventional angiography, we can't see it. We don't know it, and therefore he must not have it. And we can't see by conventional angiography these vessels. You can see maybe how this vessel here could look a little bit like this here. And these are vessels 500 microns. So now we know that the patient has some blood supply to his posterior circulation. It's off of branches that he made, probably the artery of Borniscone Castanari coming off the carotid artery, filling the posterior cerebral arteries, and then filling the brainstem. Well, let's look at a blood flow study and see what happens. In the resting blood flow study, you know if it's blue or green, the blood flow is pretty good. But then they challenged him by giving him acetazolamide or challenging him with diuretic. And you see in the front part of the brain, the circulation went up. It becomes very, very, very robust, very active here, but it becomes much less in the occipital lobe. And if you look at the brainstem and the cerebellum, it's much less than it is in the resting state. So what it tells us under a challenge, his blood flow goes to the front part of his brain and it's stolen from the back part of his brain. Now, this is 2014. And using 7 Tesla, these people demonstrated things that we don't know then and we probably don't know today because most people don't have this. And what they did at the time is they went ahead and did a superficial temporal artery to posterior cerebral artery bypass. And you see it's filling the posterior circulation. So here is an example of diagnosing small vessel disease in vessels less than 100,000 microns, diagnosing it, finding out the cause, and then finding a treatment for it. So we can treat some of these diseases. Now, the question is, and we'll come back to this slide, how do we treat the blood vessels when they have atherosclerosis or the fat-laden macrophages in the lenticular striate arteries? This is a 7 Tesla scan, and you can see these small vessels in the brain. We're looking at vessels less than 1,000 microns, 500, 400, 350 microns. These are all what these vessels look like. So we can see them. We don't know how to see them at the origin. We'd have to take coronal sections, look very carefully. I don't know if anybody has done that. I haven't read a paper showing that. So what we find is if we have a 7 Tesla imaging system, it is far better than no imaging. And this was introduced, MRs were introduced in the 1980s, 1990s. And so we're talking about something that's 30 years old. And we're talking about a 7 Tesla magnet that just, there aren't many of them around the world. So most people aren't studying this. And so now we can see things that we couldn't see before. And if you look at this other image, which is colored, you see the white matter with a 7 Tesla magnet. You see things that we could never see before. So the answer comes to be, just because you don't see it doesn't mean that there's nothing there. Just because our imaging doesn't show us what's going on because it's not good enough, it doesn't mean that there's nothing there. And we just showed you some detailed examples of how using 7 Tesla, combining it with an angiogram, you can see things you couldn't see by angiography, and you can only see them by MR imaging. And you can make a diagnosis of small vessel disease and treat it. Just because you don't see it doesn't mean it's there. Let me go to another subject for a minute. I'm going to tie these all together. Atherosclerosis is a disease which is common around the world. It is a major health problem in virtually every country in this world. And we've seen this for years. We've treated it for years. And basically, we treated it with drugs called statins, which are supposed to diminish the amount of fat in the blood and then fat in the blood vessels. But that's not the cause of the disease. And a lot of the research work that's come out recently says that atherosclerosis is an inflammatory disease. And I'll explain that to you. Here's a diagram that comes from a paper recently that showed in schematic form and imaging form what happens and how a macrophage-laden plaque develops. We have the monocyte, which is also a macrophage, attaches to the endothelial cell. It goes through the cell right here. It enters into now the endothelium, below the endothelium. Below the endothelium, there is smooth muscle in the cell. And the fat particles in the blood also come into the blood vessel wall. The macrophage then takes up these low-density lipoproteins, and it becomes larger and larger, becomes a foam cell. And the foam cell then begins to fill the plaque here. And these cells then release other messengers, which cause more monocytes or macrophages to come in, grow, and the plaque in the brain or the plaque in the carotid artery grows. The center of it becomes necrotic. You've seen that. And it grows and grows, and sometimes it can break through the endothelium. When it breaks through the endothelium, it exposes the contents of the plaque, which are thrombogenic. They attract platelets, and the platelets and red cells form a clot. The clot can break off and occlude the vessel or cause an embolus. This is what's happening. And that's what's called atherosclerosis, is an inflammatory disease. So people have tried to treat it. They tried to treat it with antibiotics, and that didn't make any difference. They've tried to treat it with different things, different kind of agents. That isn't made an effect yet. Now I'm going to show you something else so we can tie this all together. Everybody on the call knows about cerebral aneurysms. It's common in Japan. Between 2 and 5% of the population have aneurysms in Japan. If you have an aneurysm and you get a stroke or you get a rupture of your aneurysm, 10% of these people, of all the people who have stroke, die. If you have a ruptured aneurysm, there's a 50% mortality. So as a health issue in Japan, they asked the question, how can we diagnose aneurysms early and then treat them? Because they have a large percentage of patients with unruptured aneurysms. And they did some studies in animals and humans. This has also been done in Finland, that showed there are inflammatory cells around the aneurysm. I'm going to show you about that. Here's a paper, comes out of 2019 in Japan, and the title is an intracranial aneurysm as a macrophage-mediated inflammatory disease. And what they found is if you look at this diagram, here's the blood vessel. If there's a break in the endothelium, the monocyte or the macrophage I told you about can migrate through into the muscular and subendothelial layer. The macrophages begin to proliferate and grow and reproduce because there's a genetic feedback mechanism that makes that happen. So it continues to grow. As it grows, it destroys the muscle. As the muscle gets destroyed, all you have left is the endothelium and the adventitia, and an aneurysm forms. But they also found in their experiments that there are certain agents that you can give that will inhibit the growth of the macrophage or the monocyte that goes inside the blood cell, some of which is driven by its own genetic code. And there's other drugs that will stop the growth of the macrophage. Here's another one at a receptor site on the macrophage in the membrane. Okay, now let's go to the next. What they did is they took some animals, and in the animals, they could find that aneurysms would be reproduced routinely. And they were able to image them, and they could image the animals that had aneurysms. And what they did is they took one of those agents, and I'll show you what that is. It's an EP2 antagonist, and I'll show you on the diagram where it is. That's here. This is an antagonist at this receptor site, which then blocks it and will not allow it to be stimulated to grow. So they gave the animals that, which is that number, that vehicle. And then they had a control group, and they continued to image them. They found in the animals that what would happen, this is how the aneurysm will look under their imaging system, and the dye is really staining the smooth muscle in the wall of the blood vessel. And you can see here's an aneurysm because there isn't much muscle, and it's all being replaced by endothelium and adventitia, so we get an aneurysm forming. Now, if we give these animals this agent, this EP2 antagonist, what happens, and you follow them over time, is that aneurysm is repaired. Because what they've done is they've stopped the growth of macrophages in the blood vessel wall. It stops destroying the muscle, smooth muscle, and the aneurysm can then repair. If they don't get it, the aneurysm will go on to develop. So now what they have is a method of detecting if there's an aneurysm, and they have a method of following it and treating it. Okay, let's go to the next paper. Same investigators, another paper, 2019, macrophage imaging of intracranial aneurysms. And what they did in this study is they injected iron particles in through the blood vessels in the animals, injected iron particles. If there was an aneurysm, but it was early stage and there were no macrophages there, there would be no staining and you would see no macrophages here labeled from the iron. This is just a diagram. However, if there was an aneurysm, it had macrophages there. The macrophages would take up this dye because it has iron in it. You would see it on the imaging. This is an MR image, and you would know that there's macrophages in the blood vessel wall, and you know that the blood vessel then would be prone to rupture because these macrophages are destroying the muscle. This is a little higher power view. If you look at the macrophages there, this is a macrophage. This is a nucleus. This is before giving this agent, which has got iron in it. And you give the animals the agent with the iron, and you see these dark particles here. This is either all electron microscopic views. This is a higher view. So you're seeing this in a higher image. And you see the iron particles in the cytoplasm. And if you take this image here, and you subtract this image from this image, you're left with iron particles. That's what happens with subtraction angiography. And this is just subtraction MR imaging. So if you look down here, this is an MR image of the animal with the aneurysm before giving it the iron. After giving the iron, you can see this is much more detail. If we take this and subtract it from this, you get this image here. The white shows the aneurysm. This, the two red arrows show the iron particles that are left, just like here, when we subtracted this image from this, the iron particles that are left in the wall of the aneurysm, except for this part here with yellow, which didn't take up iron particles, which meant there are no macrophages there. It's around the neck of the aneurysm, which we know is stronger than the dome. So now we have a method of following this. If we can give them this agent and we can see which aneurysms are growing, which ones will rupture, and therefore which ones we can treat. So for Japan, in which 2 to 5% of the population has aneurysms, now we have a method of diagnosing which ones have aneurysms, and we have a method of treating it. But there's a problem. And the problem is this dye that's used for imaging is too toxic. And so they can't use the dye. So they've worked on a variety of other, I'm going to show you this again, other compounds that they're working on this now, other compounds that you can use that can stop the macrophage from growing. Obviously, this is the one they used, the EP2 antagonist. And they're working on another compound for imaging that isn't toxic. So now, what have I shown you? I've shown you that with Dr. Miller-Fisher's work on lenticulostriate vessels causing capsular infarcts, that in which that is atherosclerosis or a fat-laden macrophage, which causes a blockage of that vessel and leads to 20% of strokes, which now we can't treat, we can't diagnose it, and we can't treat it. I've shown you that atherosclerosis is an inflammatory disease, and we've just shown you that it's a macrophage monocyte-driven disease, which goes into the blood vessel wall, and with the fat particles in it, and it causes a plaque. That's what Dr. Miller-Fisher was saying. So we now know what's causing atherosclerosis, a major disease around the world. We're trying to find a treatment for it. We don't have it yet. And in a country that has a large number of aneurysms, we find that the cause of aneurysm is a macrophage-based infiltration of the vessel wall. And we found that there are agents we can use that can stop the macrophages from growing. We found that there are ways of treating it so that the aneurysms will then go away. We now find that there's a way of diagnosing it, but the dye is too toxic, and we can find out which aneurysms are growing and which ones have macrophages in the wall. What have I just told you? I've told you that a major disease in the world, we've now found the cause, which is an inflammation. I found you that told you that this disease caused 20% of the strokes in the world, which nobody knows how to treat for 40 years. It's also causing aneurysms, which we've known about for years. We know how the aneurysm is being formed. We know what's happening to the wall. We know it's a macrophage, and there are treatments out there that will inhibit the growth of macrophages. I'm going to ask you a question. Do you think that this disease, atherosclerosis, capsular infarcts, and aneurysms will be treated in the next 80 years? The answer is obviously yes. Well, what does that mean for neurosurgery? What does it mean for carotid endarterectomy? What does it mean for bypass surgery? You have to think about that. A major disease in the 21st century is going to be inflammation. I'm going to tell you why in a minute. Inflammation. I've just shown you a major problem in blood vessels due to inflammation. Okay. Now, it turns out that other diseases are caused by inflammation. Published a paper in Surgical Neurology International. Most people, it was so new and so controversial, people didn't want to publish it. We are interested in those papers. We published it. And what they found is that Parkinson's disease, neurodegenerative disease, is a macrophage-induced disease, which causes, and I'll explain this, immunoexcitotoxicity as the major cause of neurodegeneration. What happens is the microglia or the macrophages, which come into the brain, become activated in inflammation, in diseases like COVID or encephalitis or Parkinson's disease, either because you've taken a toxin or had some viral attack, but it doesn't happen right away. What happens is when these macrophages go into the brain, they release certain signaling messengers which open the neuronal cell pores to calcium. The calcium infiltrates the neurons and the neurons are killed. It also infiltrates the astrocytes. But people aren't looking at that. What we do is we, in the 1960s, gave patients with Parkinson's disease L-DOPA because we were replacing the chemical that those neurons were making, and therefore the patients got Parkinson's disease. When we gave them L-DOPA, it went away. But the L-DOPA had toxicity. So we still had surgery to do for it. Well, we had a cure, a chemical cure for that disease. And now we know what that disease is caused by. Most people don't know this yet. Most people haven't accepted this concept, but it's well established. You can look in the journal. And it turns out that there are other diseases that are based on inflammation. I told you COVID. COVID causes inflammation. You know that there's long COVID. It's because it's inflammation of the brain. They lose a sense of smell. There are studies showing infiltration of macrophages and monocytes into the brain. I've told you about Parkinson's disease. It also can be related to Alzheimer's disease, ALS, other neurodegenerative diseases. But those are diseases treated by neurologists. if you had a laboratory and you were interested in aneurysms and macrophage diseases, wouldn't you want to have a scientist in your laboratory who would study that? It also is atherosclerosis. Sure, you would. Inflammation is going to be a major disease of the 21st century. We're going to find all the causes of it. We're going to find treatments of it, just like we did with penicillin for infection. Neurosurgeons don't want to hear this because it means you're not going to do much surgery. You're not going to stop this from happening. It's going on all the time. This progress is being made in other specialties that are looking into this. What about spine disease and arthritis? Everybody in the world gets arthritis. It's because the cartilage wears down, it's not being replaced, and there are experiments in the laboratory which shows that you can either put in stem cells or find various transmission factors that can be stopped or reversed, and the cartilage loss will stop. It can be reversed, the cartilage will grow. Then you won't rub bone on bone and you won't get arthritis. There's another disease, rheumatoid arthritis. I had a variant of that. And this was one of the early treatments for it, which was an anti-tumor necrosis factor drug, which goes back and can treat that. And I'll go back to this and I'll show you. Here is anti-tumor necrosis factor inhibiting this messenger on the macrophage. That's from the Japan article. Okay? And so we can treat rheumatoid arthritis, and with that, psoriasis, just a skin disorder. What am I telling you? All of these are chemical treatments for diseases affecting all of medicine. Well, what about this? There are other treatments. They're called precision medicine, molecular medicine, genetic medicine. There are people in Africa, it's usually predominant in blacks, who get sickle cell disease. It's caused because of a genetic defect that allows the protein inside the red cell to become deformed, and it forms a sickle-shaped red cell, which then clots because it can't smoothly go through the blood vessel, so it piles up and it clots and you got a blood clot. Well, what they found now is what the gene is. They can take some of the patient's cells out and replace that gene by cutting out the defective gene, put the cells back into the patient, and they will grow and the disease will be cured. Major advance in medicine. Cavernous malformations, which we see, has the same genetic defect as meningiomas. It's a signaling pathway defect, genetic defect. We can treat that. I talked about cartilage. Here's the paper on treating sporadic cavernous malformations, going into the genetics of that. Here is the technique they use. It's called CRISPR, which essentially breaks up the gene and takes the defective gene out so the gene will be normal. Here's a paper in Brain Research just came out in 2021 showing a pontine glioma, diffuse intrinsic pontine glioma that cannot be treated by surgery. Nobody knows how to treat it. And there is a receptor on one of the sites in the tumor, which if stimulated will make this grow, this glioma grow. You can stop it. That disease can be treated. And people are finding now in trauma that the secondary cascade that occurs in trauma, there are certain agents you can give that slow down the secondary cascade so the infarct won't be as big. So where will neurosurgery be in 2100? Vascular disease should be cured. That's 80 years from now. Neoplasia, I just showed you. We're on the way to treating that. Degenerative and metabolic diseases, inflammatory diseases, we've talked about that. Spine, we've talked about that. The reason nothing's being done, if you look at the spine journals, they're all reporting one new technique after the other, because treating it chemically doesn't make any money for the manufacturers. Sorry to tell you that. You know it. Functional neurosurgery is going to be tremendous. We're finding out all kinds of things with imaging, fiber tract imaging. We're finding out we can treat obsessive compulsive disorders, many psychiatric diseases. Couldn't treat them before. We didn't know what caused them. There are other diseases, autism, other diseases we can find out and treat. Infections I told you about, toxic. I had a friend who was a neurologist who liked to develop his own pictures in the laboratory. He would go down, close the doors, he would inhale the fumes from the developing material for the photographs. He developed a toxic encephalopathy that killed him. It was a neurodegenerative disease that caused neuroinflammation in the brain. What's happening in myelodysplasia? An article that just came out 7 months ago. It was a study that was done showing that if you operate on the fetus who has a myelomeningocele and you repair it in utero, after birth, that young child will have 50% less chance of having hydrocephalus and other complications from that disease. Major advance in medicine. What is it going to take to do this? Well, maybe you do this in your hospital. It's going to take multi-specialty teams, not only of neurosurgeons, but neurologists, basic scientists, chemists, pharmacologists, everybody working together to solve this. That means we're going to have a whole new structure of education and a whole different structure of compensation. What are the diseases going to be at the end of this century? People are going to live longer. Everybody on this call, except me, is going to live past 100. People born today will live past 100 if they don't get overweight and don't get obese. 50% of the world's obese. They'll die early. They're killing themselves. Aging. People are working on this, finding chemical cures for that. We're going to be in space. We're already in space. What do you do with people who get sick in space? It's going to be space medicine, space diseases. Just because you can't see it doesn't mean that it's not there. I'm telling you things that you can't see. It doesn't mean it's not there. Here's the proof. This July, a new telescope was launched. It was able to see parts of the universe that we couldn't see before because it was using infrared radiation to image it. And this was a picture out of a very narrow field in the telescope showing thousands of galaxies, thousands. And if we had the whole 360-degree view, it would probably be millions. The question is, are we alone in the universe? What's the likelihood? We are the only civilization in the universe. You answer that. 1 in a million? Not likely. So that's what I've tried to do, is to give you a talk about what the future of medicine and neurosurgery is. So we can have some questions. I'd like to give you a little advertisement here about where you can find some of this information. You have your own journal. We have two, and I'm going to tell you about them for just a few minutes. One is Surgical Neurology International. You know about it. 16% of the Chinese neurosurgeons read it. It's in 239 countries, and it's the third most read journal in the world. It's free. It's free. It's been free since we founded it. And we did that because we knew that there were people all over the world who couldn't afford to go to meetings, couldn't afford a journal. And journals are becoming more expensive now. I'm going to show you this. This is the home page of Surgical Neurology International. If you put in a search term here, you can put in a search term. It'll go through our 6,000 articles in the library over 13 years and search for whatever term you want. Down here in the bottom, we have the papers that are published. Here's a paper that was just published 2 days ago. It tells you how many people are reading it. We don't have an impact factor because we don't think that tells you truthfully who's reading it. We have papers that are read thousands of times. Well, if somebody doesn't quote that for some journal, it's not going to register in an impact factor, but yet it's highly popular. I just told you a whole bunch of things this morning you're going to go around and talk to your colleagues about. That's not going to be a published article. It will be, but it's not now. So how many people are going to know it? And so if you want to download it, you go here, you can download the article, you can print it out on your computer. And if you want to do that, you can go up to the menu, and if you want to read it in Chinese, you do that. And the article comes out in Chinese. This is by John and I were talking about, by artificial intelligence. You have to know something about artificial intelligence. It's not 100% accurate. What goes into the machine and what comes out of the machine. It can't make things up on its own. It is not smart. In fact, if the database is not a complete database, you will only get selected information. So ChatGPT has some serious downsides. We're not going to have papers that are printed by or made up by ChatGPT. I want to know what the investigator sees. That's why we have case reports. Because case reports tell us what you don't find in a randomized study. It tells you what the individual investigator sees. These are novel ideas. ChatGPT can't find that out. It doesn't exist yet. So this is free to everybody. You can do this. It's in your language. You go up to the menu. You can put in whatever articles you want to read, what the type of articles, gives you the various subjects you can go through. You can do that. We can go and there are ebooks on this.
Sorry, sir, we can't see the slides.
You can't see the slides. Okay, I'm sorry. All right, I'll have to find another way to do this. If you'd be patient with me, I can do that.
Just the last part. The other slides were very well.
Okay, now we should be able to see this in a minute here.
Okay.
I'm going to have to stop share. I'll be finished in just 3 minutes. And here we go. You should see that, right?
Yes.
So that's surgical neurology. That's the home page. That's the search bar I told you about. This is the menu here with the articles. I told you about that. I told you if you want to look at an article, you can see it here. You can see the number of page views. And I told you if you want, you can translate this into multiple languages, and Chinese is one of them. Okay? And so that's, it showed up before, it doesn't show it now. Okay. So anyway, that's that. Now we have a second journal. This is free. This is the second journal. You should see this. It's on your screen. It's called SNI Digital. We just launched this 30 days ago. It's a video journal of neurosurgery. And what we have here on the blue side, we have all the new editions. This is version 1.0. We're coming out with version 1.1 in another 2 weeks. It's constantly updated. It's the most modern technology we have. You can still select whatever language you want. And this lists a number of major talks we have that are all been highly rated. This is spine disease, pediatric brain tumors, memory disorders in the brain, how you can treat that surgically, critical care, what to do for gliomas, interview with Dr. Hernasnimi, who know epilepsy. This is a talk here. There's an outstanding talk on what stereotactic and functional neurosurgery will look like by the end of the century. And when you go and you click on that and you see 3 things, you see this is the video, you see the audio portion here if you want to multitask, or you can see a transcript. And I'll just show you. Here's the video. Okay, and the video will play the video, and with the video is closed captioning. If that's not good enough and you just want to go audio, you go down here and you click audio. and it'll give you the audio transcription of the meeting. Or you can go down and here's a transcript by AI of what was said during the meeting. And you can put all this in a different language. It's in Chinese. Now, AI isn't perfect, so it's going to make mistakes, but it's getting better. I just tested it 2 days ago compared to 2 weeks ago. It was amazing improvement. So this is another opportunity to learn. And to learn, again, it's free, lots of different things, but this is video. And we're working on getting CME for this. So there are ways you can get information, both now two-dimensional from journals, your own journal, and three-dimensional from this. There's lots of things on the internet, but the problem is we don't know how good it is. And it's not peer-reviewed. All of this is peer-reviewed. So that's what I wanted to tell you about. I've told you about what I think the future is of medicine and neurosurgery. Now I've told you about the future of publishing. It isn't going to be journals. It's going to be what we're doing right here today, talking to each other. Because the fundamental principle behind SNI Digital is people want discussion of information, not just more information. We want to talk to each other, ask questions. That's not done. That's what we do on SNI Digital. So I want to thank you for the opportunity to come and talk to you. I want to tell you I appreciate it. And I'll give it back to you, John.
Thank you. Okay, Ben?
Okay, thank you, Professor Ausman. Very informative presentation. And actually, we learned a lot from you again. And you said that maybe here some neurosurgeon can live more than longer than 100 years.
Yes.
And but actually with the I think actually with the help of the AI, we called some digital life forever. Yes, maybe you can yes, you can make the first neurosurgeon in the digital world live forever.
Thank you. I don't think that's going to happen, but it's going to tell you that in the 21st century, people are going to be living a long time, more than 100 years. And we have some more questions to ask: what diseases we have, how are we going to treat that, what are we going to do with our competitors or colleagues in space? They're going to have different problems than we're dealing with today. I won't be around for that.
Actually, Professor Ausman, do you think that we admit that some of the aneurysm may be caused by the inflammatory, but actually, I don't think all the aneurysms was caused by the inflammation, because after you clip it, actually you. In most cases, you can cure the disease, and if it's all because of the inflammation, it can be recurrent again. And do you think that like aspirin can prevent the inflammation of the aneurysm and help in preventing the hemorrhage?
I know what I said in my talk that the Japanese are doing is they do think it's based on inflammation. And so what we have to do is stop the macrophage from destroying the blood vessel wall and creating an aneurysm. And aspirin won't do that.
Yeah. Okay. Thank you.
So we need some new drugs.
Yeah.
If you want, I guess there's some questions.
Yeah, Dr. Bahani, do you want to ask a question?
Thank you very much. Nice talk. Thank you very much, Professor Ausman. I do believe that this inflammation, most of the cases that you told us, also disc herniation is some kind of inflammation. And about the aneurysm, aspirin, here in Holland, there's a trial just to see how is the results. I expect that there should be a revolution to treat also aneurysms because of the inflammation. So, and if the colleague told, if you clip that, of course, that part is treated. There would be no recurrence, but sometimes if it is coiled or webbed, it could grow again. So I do believe that this kind of inflammation. Just was also a comment.
Okay, I forgot to tell you that if you wanted to see this talk, it's on SNI Digital. That's snidigital.org, snidigital.org, snidigital.org. If you look that up, you'll see the talk I just gave you this morning, and you can see some of the references. You can review it, and you'll have that information. I think but I'm telling you, if I'm a neurosurgeon, I'm like you are. I like to do surgery. Before 1850, we weren't doing much surgery. When China existed as a country 10,000 years ago, they weren't doing surgery. They were doing burr holes in the skull. Why is it that today everybody thinks that we're going to be doing surgery for the next 1,000 years? That makes no sense. But surgeons like to operate. I like to operate. We're technical people. But what I'm trying to show you is that there are advances going on in medicine that neurosurgeons don't know about that are going to affect the specialty. 20 years ago, I wrote a paper about the death of aneurysm surgery. After I wrote that paper, I was never invited to a vascular meeting. And I said that most of aneurysms will be treated by interventional because we had a superb interventionalist working with us and coils. And I saw it with my own eyes. Most didn't want to believe it. So they figured, well, won't invite the messenger, so I won't hear the message. Now, most aneurysms, except in the developing world, are treated interventionally. The disease is going away. Parkinson's disease, I told you, is treating by L-DOPA. It's not good enough, but it's there. Infections, we've told you about all those things. But surgeons have a difficult time understanding that these changes are going to happen. Is it going to happen tomorrow? No. I just showed you these papers from 2014, 2019, 2021. That's anywhere from 9 to just a couple of years ago. And these changes are happening. What's going to happen in the next 80 years? And what do you do about it? There's another question. Martin, you had a question?
Professor Ausman, actually, I have another question.
Sure.
What's your opinion on the AI? Because do you mostly think it's helpful and positive, or also worry about some the negative side? Because as we can image that the AI also can have some negative effect on the patient's thoughts, or some misleading some neurosurgeons' opinion. Do you think maybe it's helpful in the real world research, but also can cause some, if the like a big company from the medicine company or some bigger company, they can maybe manipulate the data and misleading some doctors. Do you think it's possible?
Well, you answered a lot of the questions yourself. Let me give you a couple of examples. In World War II, people developed the use of understanding of the basic structure of life and atoms and nucleuses and protons and electrons. This had been going on for many years. But they found that they could use this new ideas and make a technology called a nuclear weapon. So this was taking information that could be useful and using it in a destructive way. Now there was some work that was just published this past summer showing that you could, by manipulating the protons in the center, the atoms, that you can create fusion. And out of the fusion, you create energy. It would solve the energy problems for the entire world. It's called nuclear energy by fusion. So I've just given you two examples. One can be used for good, one can be used for bad. We had technology which developed the MR scan, been a huge benefit, the CT scan, huge benefit. We have technology that's developed cell phones, tremendous benefit. The internet, we're using it right now. But you also said that it can be used inappropriately, where countries or companies or organizations can put information out on the internet because they control it, and you won't get the truth. And if you don't get the truth as a doctor, you're going to make a mistake.
Yes.
If you take AI and you program a robot to shoot a basketball, that robot can make that basketball put the ball through the hoop 30,000 times in succession without a mistake. If you move the robot 3 feet to one side or the other, or 3 meters to the one side or the other, you'll miss it every time. Why? And the answer is because it needs the human interface to program the information so it can work. It's the same with AI. And I told you that in some of the things I mentioned here. AI doesn't know much about the imaging of aneurysms. It doesn't know about the concept of inflammation. So you're going to go to ChatGPT and out will come something that it'll print out, and it will tell you nothing about what's new. It'll tell you nothing about what you're going to see when you see a patient on the ward today and discover some unusual finding, because it can't do that. So what do I think about AI? I think it's tremendous. I just showed you how it translates everything immediately into languages. It has mistakes. It's getting better. Is it going to run my life? Not while I'm living, and probably not while you're living. It's not good enough. But the technocrats in the world think that that's the answer to everything. It isn't. It's something called soul.
Yeah. Thank you.
Right.
Okay,
Professor
Martin.
Ausman.
Go ahead, Martin.
Yes. I just, since I have a chance to talk to you in person here, see, in 2014-15, I got interested in the context of teaching residents, what are all these messengers and pathways and molecular biology, biochemistry, etc. By the way, there is a paper out there claiming that unruptured aneurysms treated for 1 year with aspirin are showing a decrease in size, and it is, being speculated that the inflammatory mechanism is there. But anyhow, going back to what I was going to say, so I suggested to Peter Black in 2017 in Istanbul, and I said, listen, one of the major stumbling blocks why we clinicians and certainly surgeons, we can't read these papers, and they've been, appearing in the Journal of Neurosurgery for a long time because of this abbreviation disease, basically. You get all these abbreviations, and even in the title, so it puts you off. So anatomy had a similar problem about 100 years ago or 110 years ago, maybe. And so they had some conferences where they standardized the anatomical terms. It's called nomina anatomica of basal or something rather. And I will put it to you, since you're very influential and you know all the right people, that we should have a conference where all this new knowledge about these receptors and so on are named in a better way, because some if you go on the history of some of these receptors and signaling pathways and all the rest of it, it's an absolute nightmare, and it's very, very arbitrary how they're named, and so it doesn't become clinical knowledge. What do you think?
You're absolutely right. And we're working on that now with SNI Digital. Exactly what you said is to begin to find these people who are doing very innovative ideas, and we want to put them up and so everybody can see it. And we published, as I showed you, in Surgical Neurology International, papers that were way ahead of its time. You're right. People don't want to see that, so they get rejected. We're going to do that.
Well, thank you.
Thank you.
That's
Thank
all
you
I
for-
have to say. And by the way, about 80% of the immune system is in the gastrointestinal tract. And in the context of, like trying to teach residents about the pathways, I bought a lot of immunology books, and unfortunately, the whole literature is very big, and I haven't been able to read them. But it seems that a lot of the immunology inflammation type of responses throughout the body are actually originating in the gut. What do you think?
That's correct. What you said is absolutely correct. So thank you very much, everybody. I appreciate your listening.
I agree, James. We need discussion, and that's what Zoom is for. This is a perfect tool for discussion, and let's continue.
Okay, I'm happy. I just don't want to dominate this. If you want me to answer questions, I'll do that.
Okay, any more questions from the panelists?
Okay, Professor Ausman, my last question. It's a personal question. Do you have time at June, middle of June, to come to China? From 15th to 17th of June, we will have an international conference in Shanghai. We want to invite you.
Well, it's very nice of you. Very nice of you to do that. I think you have my email address. Write me, and I'll correspond with you about that. Okay.
Okay. Thank you.
I really appreciate it. It's very nice of you to do that.
Okay.
I think Takashi Khan has a question. He's a regular here from Japan. Okay,
yes, thank you for Dr. James Ausman for the nice lecture. So thank you for citation of my colleague's paper, MC1, and information is written by our colleague, Dr. Kushamai and Dr. Mizutani from Showa University, Tokyo, Japan. And information was finding aneurysm in Japan, many MRI are available, so easily people can be diagnosed unruptured aneurysm and treated. So, but UCAS Japan, New England Journal of Medicine, and unruptured aneurysm, the natural history was found. So we are very careful to treating, doing surgery for unruptured aneurysms. The evidence is, but your lecture and very informative and for the future neurosurgery. I appreciate. Thank you very much.
Thank you. I appreciate your comment. Your colleagues do a superb job.
Thank you.
Okay, Ben, I guess we'll move along. Thank you very much, Dr. Ausman, again, for everybody.
Okay, thank you, Professor Ausman. And I think it's early morning in your city. And today we already have more than 1,000 audience in WeChat channel. They all enjoyed your presentation. Thank you very much.
Okay, thank you.
He was here early. He was here before I was.
Thank you again, Professor Ausman. And let's move to the next speaker today, Dr. Guo Xiaopeng from Peking Union Medical College Hospital, and he will introduce their clinical trial about the withholding steroid treatment before and after pituitary adenoma surgery. Okay, please, Dr. Guo.
Okay, dear Dr. Zhao, dear Dr. Xu, and dear Dr. Ausman, Dr. John, dear ladies and gentlemen online, and good evening. Is about 9 p.m. in Beijing. Hope you have enjoyed a nice weekend. I'm Dr. Xiaopeng Guo, a neurosurgeon from Peking Union Medical College Hospital, Chinese Academy of Medical Sciences. Today, I'm going to share with you a parallel group, triple-masked, non-inferiority randomized trial conducted by our team at PUMCH during the past 3 years. This randomized trial addressed a long-lasting but unsolved clinical question. Is withholding hydrocortisone during the perioperative period of pituitary adenoma surgery non-inferior to the conventional regimen of hydrocortisone supplementation for patients with an intact HPA axis, who accounts for more than half of the patients with pituitary adenomas. Let's go through some background first. Pituitary adenoma, as we know, is the second most common primary brain tumor and accounts for 90% of cellular lesions in adults. It arises from the anterior part of the pituitary gland and usually causes hypopituitarism and hypersecretion syndromes. Patients with pituitary adenomas develop massive effects, hypersecretion syndromes like acromegaly and Cushing syndrome, as well as a series of hypersecretion syndrome like hypothyroidism, decreasing patients' quality of life. Transsphenoidal surgery, either via microscope or via endoscope, is a primary treatment for pituitary adenomas in most cases. However, for patients with prolactin secreting PAs, dopamine agonists are the first-line treatment, while surgery is an alternative. Since pituitary gland is the human endocrine center, modulating the function of the thyroid, adrenal gland, gonadal gland, and the growth, surgery may impair the function of pituitary and lead to hypofunction of certain targeted organs. As reported in the literature, 30% of patients develop hypopituitarism after pituitary surgery, and the rate of adrenal insufficiency is about 10%. Adrenal insufficiency, as we know, presenting as dysfunction of the HPA axis, is the most lethal subtype of hypopituitarism, leading to weakness, fever, vomiting, low blood pressure, and even death. Since the 2 patients who developed acute and severe postoperative adrenal insufficiency that were reported in the 1950s, stress-dose glucocorticoid replacement therapy has been recommended as the standard of care during the perioperative period of major surgery. Although steroid replacement was aimed to avoid posterior adrenal insufficiency, iatrogenic Cushing syndrome is commonly seen among patients receiving routine steroid administration. Recently, one clinical concern raised that is steroid replacement necessary as a routine care for patients with pituitary adenomas? As we know, there is a consensus that patients with impaired HPA axis or low serum cortisol levels after surgery for Cushing's disease do need steroid supplementation. However, whether steroid is necessary for patients with an intact HPA axis needs to be discussed. According to the non-randomized trials, non-randomized studies published during the past decades, withholding perioperative glucocorticoids may be safe and not lead to a higher risk of posterior post-operative adrenal insufficiency and could even avoid steroid-related adverse events. So, a well-designed randomized trial with adequate sample size is needed to address this long-lasting but unsolved clinical concern to give us a very high-quality evidence. We conducted this randomized trial to investigate whether the new protocol of withholding perioperative hydrocortisone was clinical safe or non-inferior to the conventional hydrocortisone supplementation regimen in terms of the incidence of new onset acute adrenal insufficiency during the perioperative period for patients with an intact HPA axis undergoing pituitary adenectomy. We hypothesized that the safety profile of the non-hydrocortisone protocol would be non-inferior to the conventional care. So this is a single center parallel group triple masked non-inferiority randomized trial conducted from November 2020 through January 2022 at our institute. We followed the consult reporting guideline for randomized trials. These trials was performed in accordance with the Declaration of Helsinki and was approved by the Institutional Ethical Review Board. We included adult patients with radiologically suspected pituitary adenomas that needed a surgical resection while the transsphenoidal approach, whose preoperative HPA axis function was completely intact. As the eligible patients were randomly assigned in a 1-to-1 ratio to undergo perioperative administration of hydrocortisone or not to undergo that administration. A statistician generated the randomized sequence for patient recruitment using SPSS software. We used a multi-masking method to avoid possible bias, especially the selection bias and calculation bias. So this is a diagram showing the trial protocol. We can see that all patients underwent macroscopic pituitary adenomectomy where the transsphenoidal approach. In the standard of care group, hydrocortisone dissolved in 100 milliliters of saline was given intravenously on the day of operation, post-operative day 1, and post-operative day 2. And suprapsychological doses of hydrocortisone were used in this period according to the institute experience. Hydrocortisone tablets were subsequently given orally from the afternoon of post-operative day 2 and were stopped at the start of the post-operative week 3. This protocol had been widely adopted throughout China and was named the TAPER program. In the non-hydrocortisone group, however, patients were given 100 milliliters of saline followed by placebo tablets with a similar appearance to the hydrocortisone tablets, simulating the TAPER program as used in the standard of care group. The primary outcome was to assess the non-inferiority in the non-hydrocortisone group compared with the hydrocortisone group with respect to the incidence of new onset adrenal insufficiency during the perioperative period. The post-operative adrenal insufficiency was defined at the serum morning cortisol level lower than 5 microgram per deciliter with at least one adrenal insufficiency related symptom. The second outcome was to assess non-inferiority of the incidence of adrenal insufficiency during the first 3 post-operative months in the non-hydrocortisone group compared with the hydrocortisone group. And other pre-specified outcomes were new onset diabetes mellitus, diabetes insipidus, electrolyte disturbance, deep vein thrombosis, bone mineral density loss, and severe infections and so on during the first 3 months after surgery. The sample size was calculated based on the between group comparison of the primary outcome to detect a 10% difference in the incidence of adrenal insufficiency during the perioperative period. Thus, finally, the total number of patients needed was calculated at 436. Intention to treat analysis was used in this trial for all the pre-specified endpoints, and other detailed statistical methods were listed below. As a whole, 436 eligible patients, including 264 women and 172 men, were enrolled and underwent randomization, and 218 were randomly assigned to the hydrocortisone group and the others to the no hydrocortisone group. We can see that the clinical characteristics were well balanced between the two trial groups. To see the primary endpoint, the incidence of the new onset adrenal insufficiency during the perioperative period was 11% in the no hydrocortisone group and 6.4% in the hydrocortisone group. Fortunately, because the upper limit of the 90% confidential interval was smaller than the predetermined non-inferiority margin of 10 percentage points, non-inferiority was achieved for the non-use of hydrocortisone. In addition, the incidence of adrenal insufficiency in the third postoperative month was 3.7% in the no hydrocortisone group and 3.2% in the hydrocortisone group. Similarly, non-inferiority was also achieved for the secondary endpoint. There was more exciting news from the trial. The incidences of the new onset diabetes mellitus, hypernatremia, hypokalemia, and hypocalcemia were all significantly lower in the no hydrocortisone group than those in the hydrocortisone group, indicating a very favorable preference to withdrawing steroid administration regarding steroid-related adverse events. In this trial, we also dig into the mechanisms of action underlying this phenomenon. In the no hydrocortisone group, we can see that serum cortisone first decreased on the day of operation due to surgery injury, while soon increased on POD1 and POD2, owing probably to the stress reaction of the body, and finally returned to the baseline level in POM3. However, in the hydrocortisone group, we can see that serum cortisone level first increased on the day of the operation and also on the POD1 and POD2 because of external steroid infusion, and finally returned to the baseline level in POM3. Regarding the ACTH level, we found that in the no hydrocortisone group, serum ACTH first decreased on POD1 due to the negative feedback for increased cortisone level, and increased on POD2 because of self-regulation of the body, and finally returned to the baseline level in POM3. However, in the hydrocortisone group, we can see that serum ACTH severely decreased on POD1 and POD2, possibly because of the iatrogenic steroid supplementation, and finally and gradually returned to the baseline in POM3. From this trial, we also wanted to know whether preoperative serum cortisone level could predict the development of postoperative adrenal insufficiency to make the clinical safety. The result revealed that a baseline cortisol level lower than 9.25 microgram per deciliter predicted a higher rate of perioperative AI, and a baseline cortisol level lower than 8.8 microgram per deciliter predicted a higher rate of AI within 3 months. The present randomized trial evaluated the safety profile of withholding perioperative hydrocortisone for patients with pituitary adenomas who had an intact HPA axis with an ultimate goal of minimizing steroid overuse. The trial demonstrated non-inferiority of the no hydrocortisone protocol regarding new onset adrenal insufficiency during the perioperative period compared with the conventional clinical care that had been advocated for decades worldwide. Our study for the first time set postoperative adrenal insufficiency at the primary endpoint to address this long-lasting but very valuable clinical problem by using a well-designed clinical trial. And very fortunately, some neurosurgeons in our center and several other centers in China have already started the no hydrocortisone protocol in feasible patients with pituitary adenomas. And hopefully, the new concept from this trial can be applied in more centers worldwide in the coming years. This trial has some limitations. First, our study only enrolled patients who underwent macroscopic surgery, but not endoscopic surgery, and only in a single center in China. And second, the hydrocortisone administration protocol is according to our institute criteria, which may vary among different medical centers around the world. And third, the non-inferiority of the endpoint is marginally satisfied, that is 9.9% versus 10%, needing more real-world data to validate the result. Our result was published in JAMA Network Open in the last November, and I have two thoughts. The first is that young doctors, especially young neurosurgeons, need to keep critical out-of-the-box thinking. And the second is that senior doctors need more courage to accept new treatment protocols. I want to thank my powerful team at last, including our senior professors, Dr. Xingbing and Lian Wei, statistician Pang Haiyu, and my colleagues, several of my colleagues. I also want to thank Dr. Ian Dunn and Dr. Wang B for their joint training at Brigham and Women's Hospital, Harvard Medical School, and thank all the residents and nurses in the S2608 trial team. This is our hospital, Peking Union Medical College Hospital, or PUMCH for short. Known as the Johns Hopkins of China, PUMCH is the first hospital in China established that truly standardizes its regulations based on the model of Western medicine. Since its opening in 1921, about 102 years ago, PUMCH has maintained a strong commitment to state-of-the-art patient care and to advancement of medical education and scientific research. PUMCH has been a leading hospital in China for a century and currently serves as one of the top neurosurgery providers. PUMCH has achieved the award of the best hospital in China for 13 consecutive years from 2009 to 2022. PUMCH Neurosurgery are searching international cooperation. Studies on brain tumors, neurotrauma, spine surgery, and functional neurosurgery are welcome. And that's my presentation. Below are my email address and phone number. Thanks for inviting me to this international talk. Glad to be here to share my new thought, and thanks for having me in the webinar. Thank you.
Thank you, Dr. Guo, for your nice presentation. UMC hospital. So, yeah, any questions? Let me see if there's some question from the panel.
I don't see any yet.
So Dr.
Go Go ahead. Go ahead.
Yeah, I think Dr. Guo, can you give us a brief conclusion about what kind of steroid you really want to recommend for the patient, such kind of patient?
Okay, Professor John, thank you for your question. From our perspective, we think patients with pituitary adenomas can be divided into 3 groups. The patients with a low HPA axis function, that is the patients with hypopituitarism or insufficient adrenal insufficiency before surgery. These groups of patients need to use hydrocortisone during perioperation. The second group is the patients with Cushing's disease. These patients also need to use the perioperative hydrocortisone if they develop if they were cured after surgery, because the majority of these patients will go through insufficiency, adrenal insufficiency after surgery. And the third group of patients are the pituitary patients with normal HPA axis. We think this group of patients do not need the routine hydrocortisone supplementation therapy during the perioperation. But if these patients have a lower preoperative cortisone level, for example, lower than 9.25 or 8.8, we can give the patient a very intense monitor after surgery. If they develop adrenal insufficiency, we'll give them the steroid in time to keep them safe. That's my opinion.
Okay, thank you. So actually, yeah, I want to know if there are any new generation of the steroid, like some control released medicine or slow release medicine, to make the patient use such kind of drug more easy to management their cortisol level.
Yes, I know. But in our department at PUNCH, only the hydrocortisone was used because this kind of steroid is psychologically safe. We don't use other types of steroids for patients with pituitary adenomas.
Okay, thank you.
Okay, Wan Lee, Dr. Burhani has a question.
Sure, Dr. Rohani.
Thank you very much. Nice talk. You told about that this study was a microscopic study. Do you think that if you do the operation endoscopically, would be there any difference? What the results of to withhold the hydrocortisone or not? Would be any difference? Thank you.
Thank you. Because in our department, there were 2 groups of neurosurgeons. This trial was conducted in the among neurosurgeons who do macroscopic surgeries, but didn't include the patients of the neurosurgeons who do the endoscopic surgery. So we don't know if the results were different if we include the patients who underwent endoscopic surgery. But in my opinion, endoscopic surgery is more and more popular in our neurosurgery procedures, and in our future real world data. I mean, many of the neurosurgeons at our hospital are using the no hydrocortisone protocol. We can maybe summarize the real world data and answer your question. But from today, I think there may be no difference between different approach of the pituitary resection. Dr. Bahani.
Thank you very much. Yes, I got it.
Okay.
Okay, I guess we're ready to wrap it up. Wan Lee, I don't see anybody else have any closing questions or remarks?
Okay, that's okay. Thank you. So I think, yeah, today we have two nice talk. So yeah, I don't have any more want to I want to see. I think we should maybe just finish here.
Yes,
And-
yes, okay, Wan Lee, I think it's a good
Mhm.
idea. And thanks, Ben. Any closing remarks, Ben? Before we shut it.
Okay, thank you, John and Professor Ausman again, and thank you everybody who attended this great webinar. Thank you.
Okay, we'll see everybody in 2 weeks. Thank you very much, everybody.
Okay,
Thank you
Bye-bye.
very much. Bye.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank
Thank
you.
you.
Bye bye.
Bye.